Good day, everyone. Thank you for joining us on this panel, Empowering Healthcare Worldwide, as part of the activities for the Global Clinical Engineering Week from the Clinical Engineering Division. I am Fabiola Martinez, and today we are going to talk about the impact of engineers on global initiatives. And for this, we have two important representatives of this movement. So we are going to begin right now. Welcome to our panel discussion, Empowering Healthcare Worldwide, the Impact of Clinical Engineers on Global Initiatives. We are thrilled to have you join us today. This session will explore clinical engineers' role in enhancing healthcare delivery and addressing global health challenges. Our esteemed panelists bring a wealth of experience and knowledge, and they will share valuable insights into successful projects, innovative solutions, and the future of clinical engineering in healthcare. We encourage you to engage with us through the discussion. Feel free to ask questions and share your thoughts. And let's work together to uncover the vital contribution of clinical engineers and discuss how we can empower healthcare globally. Thank you for being here, and let's get started. The panel, Empowering Healthcare Worldwide, the Impact of Clinical Engineers on Global Initiatives, focuses on the essential role that clinical engineers play in shaping healthcare systems worldwide. As key contributors to medical technology management, clinical engineers ensure that healthcare facilities are equipped with the latest technologies and processes necessary for delivering safe and effective patient care. This panel will delve into how their expertise not only enhances healthcare delivery, but also addresses critical challenges faced by health systems in diverse settings. Our panelists today are Dr. Manish Kohli, founder and president of Pool Alliance for Digital Health and Equity. Dr. Kohli is a visionary physician leader with 25 years of experience in pioneering healthcare initiatives in the US and globally. He's passionate about transforming health and care through data, technology, and digital innovation. As CEO and founder of Beyond Horizon Health, a global digital health advisory firm, he drives healthcare innovation. Additionally, he serves as a senior advisor at Albright Stonebridge Group, focusing on strategic digital health initiatives. Dr. Kohli has collaborated with healthcare organizations worldwide on digital maturity, strategy, and workforce development. He has held roles such as Chief Medical Information Officer at leading health systems, including Cleveland Clinic Abu Dhabi and Johns Hopkins. He founded the nonprofit Pool Alliance for Digital Health and Equity to empower grassroots organizations in healthcare transformation. Dr. Kohli is a fellow and past chairman of the HIMSS board and a fellow of the American Academy of Family Physicians. He also contributes to the Joint Commission International Standard Advisory Panel, board certified in clinical informatics and family medicine. Dr. Kohli earned his MD from Southern Illinois University, an MPH from Johns Hopkins University, and an MBA in Medical Services Management. He completed his family medicine training at Rush University and preventive medicine training at Johns Hopkins. Welcome, Dr. Kohli.
Thank you for
Thanks. You also have the presence of Dr. Jitendra Sharma, Managing Director and Founder CEO of the AEMTC, Asia First Medical Services Manufacturing Park. Dr. Jitendra Sharma is the Managing Director and Founder CEO of Andhra Pradesh MedTech Zone, AMTC, which is world's largest medical devices research and manufacturing park. He is founder executive director of Kalam Institute of Health Technology that serves as Medical Technology Policy Institute to various departments and ministries of government of India. He is founder chairman of two medtech incubators, MediValley and BioValley, and chairman of Indian Biomedical Skill Council. He's adjunct lecturer at University of Adelaide in Australia and professor of practice in Indian academic institutions. His work experience includes at AIIMS New Delhi, World Bank, Niti Aayog, National Health Systems Resource Center, and World Health Organization. Dr. Sharma has been awarded the European Union India Award at EU Parliament in Brussels, AAMI Lofman Grichbach Award, and American College of Clinical Engineering Excellence Award for his distinguished work in medical technology sectors. He has 3 academic PhDs and is author of the book Made in Lockdown. Welcome, Dr. Sharma.
Good evening, Fabiola. Good evening from India. Hi,
Okay.
Manish.
Well, we're
Hi,
going
Dr. Sharma.
we're going to begin the first segment of the panel discussions, and it will deal with the role of clinical engineers in global health. Some of the key aspects that I would like you to comment on are the responsibilities of clinical engineering in international healthcare settings, or the leverage of the digital health paradigm from the clinical engineering, and the contribution of improving patient outcomes globally. So I give the floor to Mr. Dr. Manish to begin talking about this segment. So please, Dr. Manish.
Thank you again, Fabiola, and good morning, good evening to everyone around the world. Truly honored to be a part of this discussion and sharing the stage with the esteemed Dr. Sharma. The challenge we have globally is access to care. There are 3 billion people around the world who may have access to a mobile phone, but they don't have access to good healthcare or any healthcare. And we also have capacity constraints, absolute and relative, that result in not having the right manpower to deliver the care to the people. And I firmly believe that for us to improve access to healthcare and quality healthcare, we need to begin to function better in healthcare as a team. And clinical engineers form a core component of the healthcare team, especially a team that is leading the charge for transformation. Modern technologies create a lot of opportunity, but technologies have to be deployed strategically with the single goal of improving healthcare. And we are far from reaching that promise. And I think the future is going to be built on teamwork, of which clinical engineers are central. So where can clinical engineers play a role? Well, first of all, traditionally, everybody thinks of clinical engineers as members of the team who maintain medical devices and instruments. And I believe that what's often overlooked is clinical engineers are one of those few people who understand clinical workflows. They understand how patient care is delivered. They work with nurses and doctors. They are perfectly positioned to be upskilled in digital health, broadly speaking, to help lead and support the charge for transformation. So when we look at what's needed, first of all, we need to optimize our clinical workflows. And technology is a great enabler of that. Now, you cannot simply layer technology on top of clinical workflow and magically expect the workflow to be better. It actually involves thoughtful analysis in partnership with other clinicians and non-clinicians, and then digitizing it for a desired outcome. There are new technologies like telemedicine that create immense promise, especially for rural and underserved locations where it's difficult to get physicians and nurses to provide the care. Implementing telemedicine is not simply about having a Zoom connection or a video connection. it involved a different model of care. And again, how do you bring in people, processes, technology, and data together to deliver care in a different manner? So I do believe that, looking at innovation in how care is delivered, especially at a distance, clinical engineers play a critical role. And this becomes especially true in low resource settings where there may not be technicians, technologists, chief medical information officers to lead the charge. CEs may be the only technology resource that's available that has to manage this. And this includes things like data. Fundamentally, if we are going to improve quality of care, we need to learn to harness data for better decision making. And data is the new oil. And it does not magically transform itself. In fact, what we have done in healthcare is given our physicians and nurses so much data, they're drowning in data. We need help. And CEs can play a tremendous role in better data management, interoperability, clinical decision support, and so forth. I think device innovation and compliance, and they are different from country to country. It's a huge area where CEs have unique expertise. But fundamentally, it's really aligning technology with a purpose. And I truly believe that as part of a multidisciplinary team, CEs bring a very unique skill set, and we need to invest in newer skills so that they are truly empowered to help us deliver the promise of healthcare to improve access to quality care.
Thank you, Dr. Manish. Very important points that you are mentioning. Now, I would like to give the floor to Dr. Jitendra to hear his comments. Please, Dr. Jitendra.
Thank you, Fabiola. That I joined late. I'm traveling, so I was into a few things which required me to not be on time. Hi to everyone. I also see Tom and many other clinical engineering leaders hooked onto this webinar. Clinical engineers are two sides of the same coin. One coin is everything that consists of processes, and second side, everything that consists as products. Sometimes we flip the coin and call them data scientists, telemedicine experts, and sometimes we call biomedical managers, and sometimes we flip the same coin and to call them product specialists, maintenance engineers, installation specialists. Now, what Manish is saying is very important. We can never be complete looking at the coin from one side. It won't give us true value if we look at the coin from one side. And therefore, the pragmatic role of a clinical engineer, and today being the Global Clinical Engineering Day, the pragmatic role of clinical engineer is to see them clinical engineering health process specialist on one side and biomedical engineer product specialist on the other side. And a role of a policymaker or an administrator is to bring this gap closer and closer and merge it. Many times we see in several contexts that these gaps have become so huge that each one has become a separate trajectory. While specialization is nice, time has come that we look at it comprehensively as both sides of the coin. So that's my first point. My second point, as much as clinical engineering is about insulin pump and multi-parameter monitor and oxygen plant and ventilators and operation theater suites, which is products of the past, that much is clinical engineering for the future. Biomedicine, genetic modulation, data sciences, artificial intelligence. So my second point is, while we are privileged to have the legacy of clinical engineering through our expertise of technologies of the past, We have to quickly catch the bus, which is technologies of the future. Because unless we complement our knowledge of the past with the technologies that are emerging, uh, we wouldn't be able to provide the right support system to our hospitals and clinical care settings. And my third point is fairly simple. The third point is the skilling, certification, accreditation, whatever name we may call it, seems to be an agenda of clinical association. Since its ability to save the skill is not dynamic, you have skilled a person, you see his or her merit only 3 years later or 5 years later. It doesn't show up immediately like fixing a ventilator. And skilling has many dimensions. As much as private sector and health facilities love and resource the component of skilling, we need to bring in government buy-in into skilling in every single context that we are. Unless the government buy-in comes in skilling, the ability of the inflection point of skilling and the impact it can make doesn't come. So I'll stop here by saying clinical engineering is two sides of the coin. We must look at it comprehensively, which is process and products. Two, we must bridge the gap between the traditional technologies and emerging technologies. And three, we must bring in the private sector and the public sector closer into skilling. And I'll stop there. And forgive me because of internet if I miss out on any.
Okay, thank you, Dr. Sharma. It is very complete, your exposition, and together with Dr. Kohli, I think we have a very, very strong framework from begin to discuss this important topic. Thank you, and you hear very well, Dr. Sharma, and thank you for your effort to be with us here. Well, from this point, we can jump to the second segment of discussion, that it has to do with the challenges and the solutions. And in that sense, what some of them have been mentioned before, and but I think we can point of the most significant in the present time for the clinical engineers in order to face the implementation of the global initiatives on health, no? And how can they be addressed through collaborations between the organizations that are formed to this purpose, and through innovation, as you have mentioned it before. So we begin this second segment again with Dr. Kohli. We hear your comments now. Thank you, Dr. Kohli, and the floor is yours.
Good.
You're...
This is such an important area, especially in some of the markets that we are operating in through the Pull Alliance. We have an amazing group of frontline organizations and healthcare workers who are doing the best they can to overcome the friction it takes to deliver healthcare. And echoing what Dr. Sharma said, trying to solve the problems using old methodologies is simply not working. And not just clinical engineers, all of us are facing tremendous friction in doing the right thing because we have limited resources. Whether the funding is not deployed correctly, I do believe that there is significant amount of funding that's being deployed, but it's not done in a manner that is leading to outcomes. So we really need to begin to pay attention to these grassroots organizations and recalibrate on how and where we spend the money on what is spent on. Second, the correct technology is often not available. And I love what Dr. Sharma said again, right? Oftentimes the gut instinct is, let's use end of life cycle equipment, old technology in these settings. And I will say that we have a unique opportunity right now to do what we did in the telecom era, where mobile phone helped a lot of lesser developed countries, including India, leapfrog. And that has changed the face of communications globally. And I think we have to think like that in healthcare. Rather than deploying an end of life cycle ultrasound for which there may not be spare parts, or there may not be training, should we be thinking about newer generation portable technologies that can actually do a lot more with lesser skilled personnel through the power of technologies that back it up, like AI and telehealth? So I really believe that there's an opportunity for us to say strategically, what is the right technology? The unit, the cost of the device might be more, but the overall value is going to be significantly more. And ultimately, we have to really look at, are we improving access to care? So I really believe looking at this, but fundamentally, we also have to look at some basic infrastructure and where investment needs to go in. And this is where I would say that we need to lead the charge with the government and the funding bodies like the World Bank to fund those initiatives that allow us to accelerate such deployment. I firmly believe that technology is no longer the barrier. It's human mindset. And there's no better example than COVID. For all the harm it caused, all of a sudden regulations and funding became available for us to do telemedicine. So I do believe we need to sort of get in that mode that we are in a crisis situation. It is not okay that nearly half the world's population does not have access to healthcare. We are only going to be as good as our weakest link when the next pandemic comes around. And so I think resource allocation is one point. The second point is regulatory compliance. Regulations oftentimes lag technology. This is true worldwide, whether lesser developed, whether it's advanced economies. And we have to work with the regulators to say that how do we advance regulation that is future facing rather than lagging. Workforce shortages are there. We do not have enough. Also, don't use their time. A professional is because of poorly deployed technology or because of lack of technology, that is a lost opportunity. 3%. I think interoperability, and this touches on regulations, we need to be thinking about data differently. So while we want to protect the data and privacy, we also need to keep in mind, who are we serving? Is this a patient we're serving? Or are we serving the data? So we really need to strike that balance between patient care and privacy. Culture becomes really important. While 70% of backend technologies can be standardized, 30% is very local. And I think
is that my internet or Manish's internet? I think it's I think okay.
I think it's Manish.
Yeah.
Let's see if he
But
return.
let me cover
Please.
it up for him,
Please.
because just carrying forward on the point of resource. The resource has these two fundamental parts of resource that comes due to encouragement and resource that comes due to revenue. Now, what comes through encouragement is really like a child. When the child is small, you give them a toy. When the child is big, you give them a bike. And when the child is bigger, you actually imagine that the child will get a car. Our calibrated resources for encouraging clinical engineering is one part, which rests on many stakeholders, including the multilateral agencies, governments, and so on. But the second part of the resource is what we get from our revenues. The revenue resource depends upon the impact we show. And I think time has also come that looking at Yadin David, Tom Joad, Elliot, Fabiola yourself, A new generation of people realize that it is necessary to show impact to survive. We will not be getting the resource on the platter. And to get that resource, our ability to show impact is not as much there as it should be. And I think that is something that we need to answer in our own community, in our own clinical engineering global community.
We have back Dr. Coley, please.
I apologize.
No
I'm
problem.
in a hotel, I'm traveling as well, and the connection dropped. So I
Okay.
don't know where I lost you guys.
Yeah, please finish your comments. Dr. Chandra did it already, so.
Okay. Yeah, I was just talking about the role of culture. Culture will lead strategy for breakfast, lunch, and dinner. So we must strike that balance. And then obviously sustainability. When we deploy technology, we really need to ensure that this is not a one and done kind of endeavor. It's actually a rinse and repeat, and where we are continuing to support the availability of spare parts, consumables. So I think supply chain and sustainability become a huge part of the equation.
Okay. Thank you. Okay, now we lost Dr. Sharma, so okay, well, let's continue. Now we can have a few minutes for interact with our fantastic audience we have today. And I would like you to express some comments or ask some questions for Dr. Coley or Dr. Sharma once he connects regarding this important topic. So anyone could have a question or comment that would like to share with us? Okay, if it is not the case, I have the privilege of count of the presence of our fantastic Tom Jodd here, and I would like to invite you, Tom, to comment something about what we have told and we have discussed so far. So please, Tom, if you'd like to share your thoughts with us, we're more than welcome.
Dr. Coley, can you say more about some of the initiatives that Pull Alliance is making to improve clinical outcomes through clinical engineering and our partnership with other key stakeholders?
Absolutely. Thank you, Tom. Yeah, so we have an immense privilege to be inspired by a number of organizations and leaders who are doing amazing, impactful work in the front lines in Kenya, in Uganda, in Zambia, in Colombia, in Afghanistan, in India. And the themes are the same. We see a promise in digital transformation, we don't know how. We lack the depth of expertise, we lack access to resources, and we desperately want to serve our patients better. And where the conversation begins is with oftentimes a tactical need. And as we begin engaging in a conversation, it gets into much deeper layers where it's pretty obvious that we need people who understand clinical workflows, people who understand technology, and people who understand the importance of resilient healthcare systems. And this is where, as we look at how are we going to get this resource pool, because we cannot deploy an entire IT team or a technology team to these settings, the role of a CE becomes really important. I'll give you a couple of examples. So we're working with an organization in Kenya that is delivering impactful care to women with complex gynecologic issues, rectovaginal fistulas due to genital mutilations or poor surgical outcome from past procedures. And they have, over the last 10 years, done about 6,000 such operations, but they're also delivering 1,500 babies. They're also doing other complex surgeries. And the conversation started with a lack of supplies, and it has progressed into we actually need to capture data better to show outcomes. Oh, and by the way, somebody donated us an incubator we really need a NICU. And the incubator, we don't know how to manage that. And there's a whole suite of processes and workflows to really set up an ICU. But at present, every premature baby is sent to another hospital and oftentimes with a poor outcome. So how do you begin a journey of helping an amazing organization like this and begin to piece together solutions that are going to serve an immediate need, but then also in the long term, ensuring that they have the necessary knowledge, the tools, the technology, and the workforce to drive that change. So when we talk about, the incubator that they've been given, traditionally CE would be saying, well, how do we actually maintain the incubator? But here we have a situation where we need somebody who understands technology and clinical workflows. So CE resource becomes really important, helping us create a NICU. And the model we're looking at is remotely managed ICU with lower skilled frontline folks and equipment that is well integrated and data that can allow it to capture quality. In Colombia, it's a similar situation. We have a CE that's working with us with a fantastic organization that flies into remote parts of Colombia and is doing impactful work. They want to embark and strengthen the cervical cancer screening program for women. And there's a huge opportunity for us to begin to look at innovative ways of deploying technology. And we have a CE leader who is actually helping us project manage, which means, is overseeing a much broader portfolio than simply a maintenance of a device. So, we've got similar stories like these, but as we look to scale our ability, the addition of CEs as a core member greatly enhances what we're able to do.
Thank you, Dr. Colley, for the fantastic effort and the excellent Pool Alliance mission that I'm sure they will be very successful. And of course, you can count on all of us for doing that.
Thank you. Well, I must add something. We have another CE leader who's actually we're working with to develop a residency training program for CEs in Uganda.
Oh,
and bringing a program like this to Uganda not only serves Uganda, but can help patients in Kenya, patients in Zambia. So I believe that initiative led by CEs, which this one is a residency program, can have ripple effects far beyond that individual program. So I am actually grateful to have your partnership and support in doing something that is ambitious, but something we believe is doable in our lifetimes.
Excellent. Excellent. Thank you, Dr. Colley. Okay, let's open the mic to anyone who wants to comment something or ask any question regarding this topic. Would like anyone to do so?
Hi, good morning.
Yelena, yeah, of course, please.
Yeah, good morning. Thank you very much for both for your share with us your experience. I have a punctual question. I would like to know how I can propose ideas to improve the way of working in my area with artificial intelligence. I work in a clinic. So because when I started working on my clinic, I proposed a methodology to improve incident management. But they didn't want to invest in new methods that will allow for more efficient work. So for me, it's like I want to do new things that use artificial intelligence or data science, but they think that no, you want to use papers or also Excel. That is not that, but we can improve. So I really want to know how can I propose ideas and my area or my boss can hear me to allow for more to improve the methodology and be more efficient at my work. Thank you.
Okay, I don't know if the Dr. Colley would like to answer the question or.
I'm happy to, but I cut out the voice cut out for a few seconds. So could you repeat the question for me, please?
is Elena
How can you
Gutierrez.
show impact to your bosses so that they allow you to do more and more things? Is that the essence of it?
Hi, do you hear me?
Go ahead.
Thank you. Okay. My question was like, I would like to know, how can I propose ideas to improve the way of working in my area? Like, in my area is clinical engineering in clinic here in Peru. How can I use artificial intelligence? Because when I started working at my clinic, I proposed a methodology to improve incident management, but they didn't want to invest in new methods that would allow for more efficient work. So I really want to know some tips that can guarantee that my boss or my partnerships can allow me to use my methodology or new methods to be more efficient at my work.
That's a very important question, and I'll
Thank
tell
you.
you that it's thank you, and I've had the privilege of working with some amazing organizations that encouraged innovation and that were open to doing things in a manner that advanced the practice of medicine, but then also allowed them to measure the improvements. I think the secret that I've found that has really helped is if there's an alignment on areas, clinical areas that are of importance to the organization, improving sepsis care or improving other things, beginning to align innovation with what is important, what is fundable, and what is likely to create impact that is important, oftentimes gets the attention of the leader. Some of this is also going beyond your immediate circle of departmental influence, partnering with a physician leader, partnering with a nursing leader, in socializing ideas and building partnerships. So I would definitely look at your boss as one vehicle, but also the broader organization as a source of innovation. But a lot of this is really aligning innovation with what is going to be important at this stage. If you're a part of a research organization and the grant funding, it's a slightly different situation, but in a clinical setting, those are some of the things that I've seen work really well in terms of getting traction. And I can give you an example actually of this. Before the pandemic, I was with an organization that everybody was asking for telemedicine, but there was no organizational support because at that time telemedicine wasn't being reimbursed. So everybody knew that through telemedicine you could get subspecialty care in rural parts of the country. But again, it was small projects coming at the departmental level. And I was talking to many departmental heads and certainly saying this is something that should be strategically funded. But it took a pandemic for the organization to say this is something we need to do. So a lot of this is really kind of understanding, what the tide is and what the organization is receptive to. Tom and Fabiola, you may have other things to add as well.
Thank you very much.
Okay, thank you. Thank you for the question and of course for the answer. And I have a question. Before we can talk about the Ricardo Silva Global Initiative, that is very important to mention, but taking from the comment on funding the projects, how hard, how difficult is it to make the stakeholders and make decision makers to be aware of the importance and the impact of this kind of initiatives with the knowledge that the funding is not low. We need a lot of money to to run such of these projects, the importance of Uganda from Colombia, and it is clear the impact, okay, the social impact on the health, but the money, where the money comes from, and how hard has been for you to convince the people to work on this project and to put the money on the project.
Yeah. You know, the beauty of this initiative is that you don't need net new money. The money is already being spent.
Mhm.
And I think one of the things we try really hard to do is begin to point out that, you know, there's a difference between giving an organization like the one we're serving 80 laptops and saying that you did something, but then if you don't pay attention that they don't have electricity, have you done any good?
Mhm.
You know, or what you see very often, equipment is donated out of good intent, but there's no training or spare parts given to the organizations. So the equipment sits in a warehouse or goes in a landfill, right? So we then say we need to improve access to gynecologic care or neonatal care, or take your condition, right, and work backwards. See what is going to be the best way, most cost efficient way to solve a problem, and cost efficient in the sense not with, you know, end of life cycle technology. Let's look at newer technologies in the mix. And then let's go to the governments, let's go to the payers saying that you are allocating $100 million for X, Y, and Z. What is the impact you are creating? And oftentimes the answer is we don't really know because nobody's collecting data. And we say, you know, another way to do so is do what the private sector has been doing, where you have teams in an enterprise that lead management and transformation. So the cost of doing it correctly is actually an investment. It's not a cost. Not doing it this way ends up becoming an expense. So we have to really say, right, how do you enable transformation? You begin with the end in mind. What is the outcome you want to create? Let's be clear on that. The world cares about maternal child health. We look at maternal mortality. We look at infant mortality. Right? Let's define the data that's needed to be captured to prove that. You know, it's once you have good technology that's integrated, collecting data is automatic. There's no additional resources. And then you begin to work with people, processes, and technology. And this is a science. This is not something that happens organically. So let's deploy the resources to help these organizations embrace that change, and then show the donors, the funders, this was the pre and this was the post. And let the numbers talk for themselves. And the thing is, you know, we have done these kinds of things in the private sector in many countries. So this is not something new. And so it's really now, you know, ensuring that we get the right people with the right mindset who are outcomes oriented to deploy the money. So my friend says, right, what do you get when you don't do technology correctly? You get an expense. What do you do when you do technology correctly? It's an investment. And it's a matter of how we choose to do something rather than, you know, what we do.
Thank you. Thank you so much for this important comments. And now we have intervention from Tom that it's important
hi,
about the
hi, Fabi.
Ricardo Silva project. So please don't come over, and then I will give the mic to Rosanna, please.
Well, it's Global CE Day, Women First. Go ahead, Rosanna.
Okay, if you like. Okay, Rosanna, welcome, and please.
Thank you. Talking about technology, it was very hard to find the code to raise my hand. Apologize, Fabi. I want to share with Manisha a concern after the pandemic, and also the amazing trends that our colleague, Dr. Sharma, has shared with us recently. Digital health is now a strong trend and core for health innovation, certainly for clinical engineers. So regarding this traditional lack of budgeting, and also this not exactly open mind from the bosses that in general we don't have clinical engineers. We know that we have to encourage and we have to innovate as well our skills to lead digital health innovations in our respective environments. What is your advice for this regard, Manish? Beyond to engage with associations as well, talking about our individual skills, what are two or one advice you could share with us today? Thank you.
So if I understand your question correctly, Rosanna, so good to see you again, by the way, and thank you for the question. It's really how do we actually get support to invest in upskilling the CEs? Is that correct?
Correct.
Yeah.
But most of all, to get the understanding that even digital health initiatives led by clinical engineers are now more than ever needed. We
Yes.
are in the trend and in the front, even they don't understand or not, or yes, see? So.
Yeah. No, I think you raise a very important point, right? That this also is a change in mindset, right? So it goes beyond just providing the skills, it's really giving the opportunity. And the fundamental question you ask is, right? We all know that digital transformation is needed. Healthcare is lagging behind. We are not serving our patients well, right? How are we going to create a workforce that is actually going to help us get there? You take a doctor or nurse out of practice, or you give them tools that are not implemented correctly, you are literally being counterproductive. Because rather than improving access, you're going to decrease access. Because if there are fewer doctors involved in patient care, if they are inefficient, it takes away from the ability to take care of patients. So the magic question is, right, how do you begin to build trust? And how do you begin to reshape the culture of medicine, right? Where teams are not limited to frontline clinician, teams are a much broader skill set. And I will be the first one to say, right, when I am delivering a unit of care to a patient, there are 100 people behind me, everybody from project management to clinical engineering to nursing to facilities, that is ensuring that I have what I need to take care of the patients. And we don't have to go too far, right? When we talk to our partners in these front lines, they don't have those teams. And you see what's happening in these settings, right? The outcomes are not there. So I do think there are pockets where I think it's easy for us to get buy-in, to create proofs of concepts. It's not a concept, it's actually proof of action. And I think recognize that this will be a process rather than something that's going to happen by one signature on a document. Now, some organizations are much more open to it. Some governments are more open to that. And that's why I think we all have to kind of recognize that for us to elevate the standing of a CE across the enterprise, we all have to kind of upskill ourselves in a way for better advocacy, right? How do we actually begin to have a seat at the table? And not just as a seat at the table, the right seat at the right table, right? And this is not new, right? When we look at the role of women in the workforce, the role of minorities, right? There are disadvantaged groups, right? So in some ways, we have a lot to learn from those areas. There's a lot of work to be done. But I will fundamentally go back to, right, what we all care about is that our patients are served better. And if you go to an organization that says, I'm struggling, I need help, I don't think they're going to care whether you have an MD or a different title behind you. They want the right skill set and the ability to help. So step by step, let's identify where we can create a model that shows what we all believe in. And I'll say as a doctor, I cannot do this myself. I need a team behind me, and again, you need to enable everybody to work at the top of their license. If we don't do so, we're really not going to make significant progress that's needed in this world.
Thank
I
you.
hope that answers your question.
Thank you very much.
And thank you, Rosanna. The question was very fundamental for the discussion, so excellent question.
Thank you.
Okay, and now go to Tom, please.
Yeah, I got all dressed up, so I'll spare you the video. I think we heard several great messages today. One is encouraging CEs and through many stakeholders. Heard that with Jatinder. We heard about the role of society. In other words, Rosanna, 10 years later, after the first Global CE Day, is our impact being felt? Is it being recognized? Are we doing more? Are we getting to do more along the lines of what Dr. Kohli, working at the top of our scope of practice? So I would say, yes, there's a lot of encouragement going on. And I'll mention something important here in a moment, I hope. I can't overemphasize the role of national CE biomedical engineering who serve at the point of care societies. I mean, Ghana in the last couple of years has broken through with government recognition of the profession because of the work of the Ghana Society. I think that's happened in Bangladesh, where they've gotten recognition from the government because of the collective work of many and the role of societies. That's happening many other places we could talk about. How important it is. Secondly, the role of society. Secondly, the publishing. I know Dr. David and Calroy will be happy to hear me say that, we've got since 2018, there's 5 or 6 issues a year of the Global Clinical Engineering Journal that is publishing these stories, which is helping one another wrestle with the kind of issues like our questioner from Peru asked, is how can I show impact not only in traditional clinical engineering activities, but emerging digital tools like AI and so forth. So the role of societies, the role of publishing, so important in sharing our work. So the last thing I'll mention quickly is, a question we've been wrestling with globally for 10 years easily is how many of us is enough? And, we're talking about CE practitioners, we're talking about clinical engineers, we're talking about biomedical engineers who serve at the point of care, we're talking about HTM managers, we're talking about technicians, we're talking about technologists. In the various settings, in the various countries, at the various levels of care, how many of us is enough? It's a terrifically hard question because of all the differences around the world and the continuum of things. But, Ricardo Silva has raised his hand and GCA CED behind him to look at that question, and the AI tools, which, you throw a lot of stuff in a pot and it gets chewed on, and what comes out of it is brilliant. As an example, of course, is Ricardo's AI produced podcast today. My point, though, is I think in the next 6 to 12 months, and I'm being conservative, we'll have staffing ratios that can get WHO recognition, and help our profession around the world. And I'm very excited about that. Many of you have been sending in, your pieces of that puzzle. And why is our hair on fire about this? For lots of reasons, but certainly at the Senegal Oxygen meeting in May this year that WHO put on, and Tazeen went representing CED and GCEA, and many others were there. Tazeen can tell us, person after person stood up. Adriano, of course, was there helping to lead it. What are the right staffing ratios? We're getting the recognition, but how many of us is of the right kinds is enough? And with the CED and GCA capacity building framework we've developed in recent years, we've got a framework on which to hang these answers. And so pretty excited about what the next year will look like. Over to you, Fabiola.
Yeah. Fabiola, if I may add a comment to that, this is excellent points Tom raised. I think the other thing I can tell you from my individual experience is multidisciplinary training. I do think that, you know, when you look at the physician example, physicians going to MBA school or physicians going into public health, or into even into engineering disciplines, it has elevated the role into other areas which are adjacent to the core practice of medicine. So I definitely think, you know, the more we see CEDs, you know, in schools of business and schools of public health and other disciplines, cross disciplines, it's going to raise awareness about the power that this profession brings in terms of advancing healthcare. So certainly, you know, the core discipline and the expanded scope of practice, but also I think beginning to look at, you know, management roles for CEs and additional training that would give them it's a different career pathway, but also in some ways it serves the CE community in a very different but a more powerful manner.
Okay.
Fabiola, I think Iwa, you know, I know
Yeah,
you're
I was about to give the floor to Eva.
Po-
Yeah.
Poland
please.
has a huge opportunity. Take it away. Iwa.
Okay. Okay, thank you very much, Tom, for your interest in our progress. I am listening with a big interesting discussion on the advanced innovations and challenges, because we in Poland, we are just at the beginning of building clinical engineering and the developing of this field. So we have very basic challenges. It means to define the field and the area in healthcare for task for clinical engineers, and of course to introduce organization which will fit to the organization of our healthcare. And the most important is education, to organize courses of clinical engineering, which will meet body of practice and body of knowledge standards international. So we are looking for any solutions which will be much easier and much quickest applied to our circumstances. So I am very, very grateful for have the opportunity to listen so many important comments and solutions, and I believe that we will be able to join quickly to this advanced level of your discussion. Thank you very much.
Thank you, Eva. Thank you for your comments. And what initially was about to be a panel became a very, very fructive discussion and very richful for everybody. We are about to finish this fantastic meeting, and by doing this, I would like to, Dr. Colley, share with us your final thoughts, your closing comments on this very, very interesting conversation we have had. Please, Dr. Manish.
Thank you, Fabiola, and thank you, everyone. You're participating and enriching my experience. I will say, right, we talk about innovation as in terms of a noun, a device, right? What are we talking about in this webinar? It's workforce innovation, right? So I think innovation needs to happen at multiple levels, and for us to begin to really come together on the problem the world needs to solve. The goals of One Health, the Sustainable Development Goals, right? These are not going to be single discipline issues. And we really need to begin to think, right? What are the boundaries? What are the overlaps? And how do we create pathways that allows us to collectively as a society achieve success? So innovation should be at all levels, not simply a noun that's tied to a technology. The other thing I will say, right, as a goal, how many hospital CEOs are biomedical engineers in today's day and age? I can talk about physicians. And I think that this may be one of the things we have to think about, right? We need to sort of encourage CEs to imagine a bigger role in healthcare and create those opportunities for training and career pathways. And I know Tom and GCEA and IFMB are all working on that. But to a CEO starting out, I would say, have you thought about being a CEO? Have you thought about being a leader, not just of your department? Because I think that's really where we create the richness, where you have folks from different disciplines coming together, saying that let's solve complex problems together, and I will bring an entire fraternity behind me. So, thank you very much for this opportunity.
No, thank you. Thank you so much for your time, your comments, and everyone to be part of the conversation. Fortunately, Dr. Sharma could not connect, but I'm sure that we'll have opportunity to discuss with him in these kind of events in the near future. And thanks everyone for coming here with this panel, and happy Global Clinical Engineering Day. Let's celebrate it very, very cheerfully. And please listen to our next events that we are going to have during this week. Next Wednesday, sorry, next Wednesday, we're going to have a very important project that CED is releasing. That is a Women in Clinical Engineering book of stories. Please join us with this important event. And the recording of this panel will be available soon, so we can reactivate all the comments and take action. So thank you, Dr. Manish. Thank you, everyone. Have a wonderful day. Happy Global Clinical Engineering Day, and see you soon.